it's Nurse Gwenny. Let's talk about the difference between an ABG, or an arterial blood gas, and a VBG, a venous blood gas. First of all, how do we get them? So a venous blood gas is going to be drawn just like any other serum lab values. We can draw it off of an IV start, or we can straight stick the patient into their veins. And the angle approach of that is going to be very nearly parallel to the skin. It's very shallow because our veins are shallow, whereas an ABG, an arterial blood gas, is usually taken from the radial artery, and the angle of approach here is going to be perpendicular. As a matter of fact, this is how I hold the needle when I draw an ABG on a patient. Now, think about how that feels. How much does it hurt to get an IV placed or a straight stick here in your veins? Not that much, right? Think about the damage that can be done when you perform an ABG. You're going through neurovascular bundles. A lot of patients end up with some kind of neuropathy to a few of their fingers or to their whole hand after an ABG. As a matter of fact, I used to work with a resident physician who allowed another resident to practice ABGs on him, and he actually lost the use of two of his fingers because of the nerve damage caused by the ABG. It goes much deeper and through a lot more structures, and therefore we've got a higher risk for damage. As well, a venous blood gas is drawn from the vein. That's a low pressure system. You're likely not going to have any kind of catastrophic bleeding from that site. Whereas with an ABG, your risk for hematoma development and continued bleeding is much higher because you're in a high pressure system of the artery as opposed to the vein. Now, the purpose of these. So an ABG, when I first started out as a nurse, that was kind of the gold standard in taking care of patients who were critically sick. And now we don't do ABGs very often at all because there's been enough literature that has come out to show us that VBGs give us almost the same information as we get from the ABG. On the ABG, the three main things we're looking at is the pH, which normal is 7.35 to 7.45. Anything less is acidosis. Anything greater is alkalosis. We're looking at the CO2, or the carbon dioxide, the partial pressure of the CO2. Normal is 35 to 45. And the bicarb. Normal is about 22 to 26. And that information is used to help us determine what pH derangement the patient has. Are they in metabolic acidosis, respiratory acidosis, metabolic or respiratory alkalosis? But we're finding through enough studies that the VBG pH is negligibly different. We're finding that the statistical difference between a pH on an ABG versus a VBG is thousandths of a decimal point. It is a very minute difference, not enough to make a clinical significance in the patient that we're taking care of. It's the difference of saying, okay, this patient's pH is 7.100 on an ABG, and on a VBG saying the patient's pH is 7.105. Just a tiny bit of a difference. That's not going to change our interventions. Now, the only time where we do need to get an ABG over a VBG is in patients in severe septic shock or patients who have a really high PaCO2. They're finding that there is a difference in the readout of the CO2 when patients are severely hypercapnic. So there you have it. There's the difference between ABGs and VBGs. What does your policy say that you have to draw?